Hello everybody. Today's topic for discussion is brachial plexus and its applied aspects at length. So at the end of the session, the participant should be able to define a nerve and a nerve plexus, describe the formation and branches of the brachial plexus, describe the relations of the brachial plexus, and describe and identify the injuries to different parts of brachial plexus and their effects. Finally, should be able to describe the brachial plexus block, its types, and their usage for the surgical procedures concerned with the different parts of the upper limb. A nerve is a whitish cord-like structure having a variable diameter, consists of fibers and fiber bundles bound together by connective tissue which transmit impulses to and from the central nervous system. Fibers are the axons of the neurons whose cell bodies are located within central nervous system. Their aggregation in the central nervous system is named as a nucleus, or they are present outside the central nervous system, that is in the peripheral nervous system, and their aggregation in the peripheral nervous system is named as a ganglia. The nerves are classified according to number one, modality of impulses they carry into sensory or motor or mixed nerves. According to their location, cranial, 12 pairs which are attached to the brain, and spinal, 31 pairs which are attached to the spinal cord. A nerve plexus is an intricate network of proximal part of spinal nerve fibers, which are actually the ventral rami of the spinal nerves. They contain both somatic and autonomic fibers. Why nature has provided nerve plexus is that all fibers going to a specific part of the body are put together in a single nerve. That is, it provides a scheme of convenience. There are two types of nerve plexuses, spinal plexuses and autonomic plexuses. Among the spinal plexuses, there are cervical plexus for head, neck, and shoulder regions, brachial plexus for chest and upper limb, lumbosacral plexus for back, abdomen, pelvis, genitalia, and lower limb, and coccygeal plexus, which is a small plexus for a small region over the coccyx, and autonomic second group, the autonomic plexuses, which are meant for the internal organs or viscera. Now the brachial plexus. It is an intricate network of nerves for innervation of upper limb and is present in the lower part of the neck and in axilla. It is formed by anterior primary rami of cervical fifth segment to thoracic first segment. It extends from spinal cord in the neck through cervico-axillary canal over the first rib and finally into the axilla. It consists of roots, trunks, divisions, cords, and branches. Formation of the brachial plexus. It is formed by anterior primary rami of cervical 5 segment to thoracic first segment. The brachial plexus as a whole may drift upward or downward. If it drifts upward, then it involves C4 with less contribution from thoracic first segment, and the condition is named as prefixed brachial plexus. If it drifts downward, then it gets contribution from T2 and less contribution from C5 segment. Then it is named as postfixed brachial plexus. Now the roots join to form trunks. C5 and C6 join to form the upper trunk. C7 itself make the middle trunk, whereas C8 and T1 join to form the lower trunk. Each of these three trunks divide into divisions, and those are ventral and dorsal. These divisions reunite and form cords. There are three cords. Lateral cord is formed by union of ventral division of upper and middle trunks. This is for the innervation of anterolateral aspect of the upper limb. Second is medial cord, which is the continuation of ventral division of lower trunk, and it is meant for innervation of anteromedial aspect of the upper limb. Third is posterior cord, which is formed by the union of dorsal divisions of all the three trunks and is meant for the innervation of posterior aspect of the upper limb. Relations of the brachial plexus. Three cords of the plexus enter axilla in relation with the axillary artery. These three cords are present above to the first part of axillary artery. Above mean posterolateral relation. These three cords approach and embrace respectively the second part of axillary artery. They give their branches which are present around the third part of the axillary artery. Axillary vein throughout its course lies anteromedial to the axillary artery. Roots of the brachial plexus lie between anterior and medial scalene muscles. Trunks are present in the posterior triangle, whereas division of the trunks lie behind the clavicle in the apex of axilla. And finally, the cords and their branches are present in the axilla. A notable point is that an extension of prevertebral fascia in the neck surrounds axillary artery and cords of the brachial plexus. This is named as axillary sheath. It is used for injection of local anesthetics for the brachial plexus nerve block. Now we start with the branches given off by the brachial plexus. There are three sets of branches. Number one are branches from the roots. Number two are branches from the trunks. And number three are branches from the cords. We start with the branches from the roots. These are number one, nerve to serratus anterior, which is also named as long thoracic nerve. Number two, nerve to rhomboides muscles, which is also named as dorsal scapular nerve. Number three, branches to the longus colli and scalene muscles. Number four, branches to the phrenic nerve. Second set, branches from the trunks. There are two branches which are given only by the upper trunk. These are suprascapular nerve and nerve to subclavius. Third set is branches from the cords. Among the branches from the cords, first branches from the lateral cord. Lateral cord has got root value cervical 5 to 7 segments. It gives lateral pectoral nerve, number 2 musculocutaneous nerve, number 3 lateral root of median nerve. Second group is branches from the medial cord, which have got root value C7 to 8 and thoracic 1 segment. It gives rise to number 1 medial pectoral nerve, number 2 medial cutaneous nerve of arm, number 3 medial cutaneous nerve of forearm, number 4 medial root of median nerve, and number 5 ulnar nerve. Third group is branches from the posterior cord. Posterior cord has got root value C5 to T1 segment. It gives rise to number 1 upper subscapular nerve, number 2 thoracodorsal nerve, number 3 lower subscapular nerve, number 4 axillary nerve, and number 5 radial nerve. Now let us have an understanding of the Erb's point and its clinical significance. It is the site at the upper trunk region of the brachial plexus where 6 nerves meet. These nerves are number 1 roots, that is 5th and 6th cervical segment roots of the brachial plexus. 2 divisions, anterior and posterior division of the upper trunk. 2 nerves, nerve to subclavius and suprascapular nerve. It is located 2 to 3 centimeter above the clavicle along the posterior border of the sternocleidomastoid in front of the transverse process of 6 cervical vertebra. Lesions at this site are relatively more frequent, and the most severe type of brachial plexus paralysis is Erb's paralysis. Erb's paralysis, which is also named as Erb-Duchenne paralysis. The affected limb is present in the waiter's tip hand position, and the deformity is present as that arm hangs by the side and is abducted and medially rotated. Forearm is extended and pronated. The disability is present as in the shape of motor loss, in which abduction and lateral rotation at the shoulder joint are lost. In addition, flexion and supination of the forearm are also lost. As regard the sensory loss, a small area over the lower part of the deltoid is affected. In addition, biceps and supinator jerks are lost. Reason for Erb's paralysis is undue separation of the head from the shoulder as shown in the diagram. This stretches the upper part of the brachial plexus. Causes include difficult breech delivery, fall on the shoulder, or manhandling during the anesthesia. It involves upper trunk of the brachial plexus, especially C5 segment, and may involve partly the C6 segment of the spinal cord. The affected muscles are mainly the biceps brachii, deltoid, brachialis, and brachioradialis. Some of the muscles may be partially affected, and those are supraspinatus, infraspinatus, and supinator muscles. Second is Klumpke's paralysis. In this paralysis, deformity is present in the shape of a complete claw hand, which includes flexion at interphalangeal joints and hyperextension at metacarpophalangeal joints. This is due to unopposed action of the long flexors and extensors of the finger. The second component is that forearm is supinated. Disability includes motor loss in the shape of inability to make fist and perform fine works. There is atrophy of hand and forearm muscles. Sensory loss is present as anesthesia and analgesia in a narrow zone along ulnar border of forearm and hand. This is due to involvement of thoracic 1 segment of the spinal cord and thoracic 1 segment of the spinal cord involvement may lead to Horner's syndrome as well. Reason for Klumpke's paralysis is undue abduction of arm as shown in the diagram. Causes include number 1, catching something after a fall from a height or birth injury. Number 2, in post-fixed brachial plexus, lower trunk has to go up and it may be angulated and stretched on upper surface of the first rib. In this paralysis, lower trunk is involved and especially the T1 segment of the spinal cord. In some cases, or partly C2, C8 may be involved. Muscle affected include intrinsic muscle of the hand because of involvement of the thoracic 1 segment, and ulnar flexor of the wrist and fingers may be affected because of the involvement of cervical 8th segment. Now let us have a brief review of Erb paralysis and Klumpke's paralysis. In Erb paralysis, upper trunk is involved, especially the C5 segment, and the deformity is waiter's tip posture. Whereas in Klumpke's paralysis, the lower trunk, especially the T1 segment of the spinal cord is involved, and the deformity is claw hand deformity. Horner's syndrome, which is also named as oculosympathetic paresis, is a constellation of clinical signs including ptosis, meiosis, anophthalmos, anhidrosis, and loss of ciliospinal reflex, etc. The site of injury, as earlier said, is thoracic 1 segment, and it is proximal to the white ramus communicans to first sympathetic ganglion. Reason being damage to the sympathetic fibers to the head and neck. And the effect produced are number 1, vasomotor changes in which the skin is warmer and drier due to loss of sympathetic activity, and trophic changes in long-standing cases may represent dry and scaly skin, and the nails crack easily in such cases. Long thoracic nerve injury. Long thoracic is nerve to the serratus anterior, having root value cervical fifth, sixth, and seventh segments. Causes of the injury include sudden pressure on the shoulder from above, carrying heavy load on the shoulder, or injury during radical mastectomy in females. Normal action of the serratus anterior is to keep the medial border of the scapula against the thoracic wall. In cases of injury to the long thoracic nerve, this normal action of the serratus anterior is lost, leading to prominent medial border of the scapula, which is also named as winging of the scapula. Disability produced is in the shape of loss of pushing and punching actions. If such actions are attempted, they lead to more prominent medial border of the scapula. But overhead abduction of shoulder girdle is partly affected, and this is because of intact trapezius muscle. Brachial plexus block is a regional anesthesia technique which is sometimes used as an alternative or as an adjunct to general anesthesia for surgical procedures to be performed on the upper limb. Brachial plexus blocks are divided into four types. Number one is interscalene block. The anesthetic agent is injected among the upper part of the roots of the plexus between anterior and middle scalene at the level of sixth cervical vertebral body. It gives ideal coverage of anesthesia for shoulder and proximal arm of the upper limb region. Second group is supraclavicular block. Anesthetic agent is injected at the level of the trunks in the interscalene groove about 1 centimeter above the clavicle and lateral to subclavian artery. It provides excellent anesthesia for the entire extremity. Number three is infraclavicular block. The anesthetic agent is injected at the level of the cords in the deltopectoral groove 1 centimeter below the level of the clavicle. It gives good anesthesia for the hand, the forearm, elbow, and the lower arm. Fourth type is axillary block, which is given at the level of branches of the brachial plexus. This procedure is performed preferably under the guidance of ultrasounds. And the site is axillary sheath, which is identified just above the pulsation of axillary artery at the lateral border of pectoralis major muscle in an abducted and externally rotated upper limb. Distal part of the sheath is closed by finger pressure against the humerus, and a syringe needle is introduced into the proximal part of the sheath, and anesthetic solution is injected into the sheath and massaged, producing brachial plexus block. It provides good anesthesia for procedures distal to the elbow. Comments and suggestions will be welcomed. Thank you for listening and watching.